Hi, my name is Victoria Crumlish, and I'm doing my project on CIDP. CIDP stands for Chronic Inflammatory Demyelinating Polyneuropathy. It is a progressive neurological disorder. CIDP presents with weakness and impaired sensory function in both the arms and the legs. CIDP is caused by damage to the myelin sheath of the peripheral nerves. The myelin sheath is a fatty covering that protects the nerve fibers. In a 2016 article in the Rhode Island Medical Journal, doctors wrote that studies of the pathogenesis of CIDP suggest that activated T lymphocytes invade the peripheral nervous system through derangement of the blood-nerve barrier. Once within the peripheral nervous system, these activated T cells generate pro-inflammatory cytokines and produce cytotoxic activity against the myelin. Symptoms of CIDP start with tingling or numbness in the fingers and toes. It then leads to weakness in the arms and legs. There is loss of deep tendon reflexes, fatigue, and abnormal sensations. CIDP is most commonly presented in young adults and in men. Symptoms can be progressive or relapsing. The myelin sheath is an insulating outer coating of a nerve. In a normal, healthy nerve, messages move very quickly. When a myelin sheath is damaged, the messages can move much more slowly. Myelin speeds up the messages or impulses that travel to the body. The myelin has breaks in it called nodes. These nodes allow the impulses to jump, so the impulses are moving very quickly. Damage to the myelin can cause the movement of the impulses to be slowed or blocked completely. Impulses would have to travel down the whole nerve, taking it much longer to get to its endpoint. This slowing and short-circuiting from the damage cause symptoms like sensory impairments. In the picture below, you can see the healthy myelin versus the damaged myelin. The peripheral nervous system contains all of the nerves outside of the spinal cord in the brain. The PNS connects the body to the CNS for information processing. CIDP can be diagnosed a few ways. Nerve conduction studies and EMGs. Electric diagnostic studies can show conduction block, prolonged distal latencies, slowing of conduction velocities, or absent or delayed responses, lumbar puncture. An elevation in a protein called CSF protein found in a lumbar puncture can help support the diagnosis of CIDP. Nerve biopsies. Controversial in its value, a nerve biopsy can show demyelination and remyelination changes, but are only seen in about half of the biopsies. Imaging findings. MRI studies may show enlargement of the nerve roots, which can reflect demyelination and remyelination. Laboratory workups. Lab workups can be used to rule out neuropathy from other causes. CIDP can be treated in a few ways. The goal of these treatments is to stop the inflammatory response in order to prevent more demyelination. Things like corticosteroids, intravenous immunoglobulin, IVIG, plasma exchange, and physical therapy are ways to treat CIDP. IVIG is proven effective and an alternative to steroids with fewer side effects. IVIG can be kept up long-term, but also can be considered for weaning after a period of stability for more than 6 months. Physical therapy can improve muscle strength, function, mobility, and lessen the risk of muscle atrophy and distortion of the joints. and this is exercise with CIDP. Patients with CIDP should always visit their physicians before starting a new exercise program. Patients may not always respond to the exercise in a typical way. Muscle fibers are recruited in fewer quantities, so patients are easier to fatigue during this exercise, making them a greater injury risk. Physical therapy should be considered for patients to aid in gait training and fall prevention. Exercise has shown to maintain and potentially improve muscle strength, function, and mobility for neuromuscular disease patients. Resistance training is important for improvement of muscle performance, while aerobic exercise can be used to aid against fatigue. Submaximal low-impact exercise is usually what is prescribed for peripheral neuropathies. Functional exercises are recommended. Residual damage is very common in CIDP, so patients need longer recovery time. It is important to progress exercises in a systematic way in order to avoid overstraining the muscles and joints. This is my case study. I used a real patient that I had in my internship. So Tom M. is a 69-year-old male diagnosed with CIDP. He has upper and lower extremity weakness constantly, in addition to constant fatigue. Tom is receiving IVIGs and has a history of hypertension. Tom is a sedentary man. Tom's goals are to maintain function and range of motion, as well as improve fatigue, address balance, improve posture, and correction of biomechanics. Tom has a difficulty in walking and also balancing and doing everyday activities like going up the stairs and carrying groceries and even driving. CIDP gives Tom a lot of restrictions, such as how much and for how long he can perform physical activities. Tom gets really tired easily. So Tom would need to perform his exercise programs as early in the day as possible to avoid fatigue from his daily activity. It is also important to stress to Tom to communicate when his body is feeling tired. With CIDP, it is easier to fatigue and overwork muscles, causing a need for an even longer recovery time, which can hurt the potential of improvement. It is also important to take Tom's blood pressure before and after and throughout the exercise program because of his history of hypertension. I wanted to talk to him about communicating because people with CIDP, it's very common that they push themselves, and this can be damaging to your program in its entirety. Okay, so for exercise testing, it's important that you closely monitor for weakness, fatigue, overheating, and worsening of just the general symptoms. Performing tests earlier in the day to prevent early fatigue from daily activities, like I said before. Also, it's important to use the RPE as well as heart rate determined intensity. The heart rate can be increased due to the disease, so it's not always reflecting the intensity of the test. It is important to warm up 1 to 2 minutes at a low level. Seated testing should be used to eliminate a fall risk in severe patients, and each muscle group and all the limbs should be tested to determine where the weakness presents itself in a patient. So I would do 4 tests with Tom. First is a 2-minute walk test for endurance. We lowered it to a 2-minute walk test just to be able to accommodate him. And as it was, he needed rest after about a minute and a half. I also performed a timed 5 sit to stand for muscular strength. He completed this in 13 seconds, which is a little long. a Berg balance test and scale for balance, which you can see I put it to your right. It's a test with scaling from 0 to 4 on how well they complete the activities. His total was 29 out of, I should say, 56. His test consisted mostly of 1s, 2s, and 3s, more leaning on the 1 and 2 sides, but didn't have any 0s, so that was a plus. And then we did a timed 18-foot walk for his gait speed, which he completed in 25 seconds, which isn't too long, but it's still longer than expected. Also for our client, functional tests are best for the program because you want to focus on improving functionality. So we'll go to exercise prescription now. For aerobic fitness, the frequency for Tom would be 3 days a week. He should perform at a RPE of 12, so it should be somewhat hard. During a talk test, he should be somewhat uncomfortable, but still be able to talk to you in full sentences. Our patient should start at 20 minutes each day. If this is too much, you want to start at 10 and increase to 30 to 60 minutes as it's tolerated. I would like to use a dual action stationary cycle for aerobics to allow the use of upper body and upper and lower extremities, limiting local muscle fatigue. Also, a stationary cycle to prevent falls and to eliminate that risk. For resistance training, I would like to do 2 days a week, and it should be at 70% of his 1RM, so he should be able to complete 10 reps of each exercise for 1 set, and then we'd like to progress him to 2 sets. When he gets to 2 sets, the patient should rest for 4 minutes in between each set to help with the fatigue. I would like our patient to do functional exercises such as sit to stands, lay to stands, step ups, and calf raises. For step ups, it would be nice to use a bench at like a lower height. Flexibility is also very important. It is important to do many times a week to ensure mobility. So I have it at 6 days a week at 1 or 2 times per day. It's important to do stretches while the body is warm. So if this could be done after a walk or something like that, the patient should stretch to the feeling of tightness and stop if there's any pain. The patient should hold each stretch for 45 seconds and repeat 3 times. Static stretching is recommended, focusing on large muscle groups. In conclusion, this disease is very tricky to use or very tricky to treat because of how quickly people get tired. So you need to pay special attention to your clients that have CIDP. I really enjoyed learning more about this, and after seeing someone firsthand through this disease, I was happy to learn how to treat them better. And then those are my references. Thank you.